Good morning, my teachers and colleagues. My name is Kemi Ashubu, and I'll be presenting a case and then some other discussions on Prader-Willi syndrome and its genetics. This is my disclosure. Prader-Willi syndrome is one of the earliest causes of human genetic imprinting of parental origin involving chromosome 15. So it means that some genes from either parent is expressed while some are silenced. The birth incidence is 1 in 10,000 to 30,000 births, and the symptoms are quite erratic. So in the early life stages, they will present with hypotonia, failure to thrive, but as it get older, then they start accumulating weight, in which they can present with obesity. So I present this girl here, 7-year-old. She's the first of a set of twins. She had actually come into the clinic a year ago on account of food craving and excessive increase in weight. She was actually born preterm at the gestational age of 36 weeks to a 42-year-old woman. And then at that initial, she had problems with feeding. So she was on NG2 for like 9 months. And then subsequently was attending a neonatology clinic because of failure to thrive, transited to GIT clinic, had a couple of visits to the pulmonologist because of recurrent pneumonia, and then also landed back in GIT clinic at age 3 when she started having increase in weight. She had followed up with them for a year, but then subsequently came to our clinic when she was age 6, when this weight just refused to go away and she was eating a lot. When she presented to us, other complaints then was that she was snoring at night when she sleeps, and then she wasn't doing well in school. She was 3 classes behind her twin sister at the time she presented. She had a narrow forehead, almond-shaped eyes, and then she was also, she also has small mouth and it was downturned at the corners. I can't show her face more than this so that I won't go against ethical practice. Her weight and her BMI was more than 2 standard deviations. So at that point, we put all this together and then looked at all her journey through life and then sent a sample for genetic testing. We couldn't do that on the patient's account because they had no money, so we had to look around for a patient association that could shield these patients and then take up the burden. That was when International Prader-Willi Syndrome Organization came in, and then we were able to do the test. So this is a methylation-specific multiplex ligation-dependent probe analysis, probe application analysis of the sample that was sent, and it actually showed that she had 2 copies of the maternal chromosome on position 15. Right now, we are managing her with lifestyle modification, so we are looking at her food portions, targeted exercises, and she's also visiting the ENT, and nutritionists are helping us. 2 reports from Africa that have been published, one in South Africa in 1998. So they actually looked at a group of people who they had thought had symptoms and signs of having Prader-Willi syndrome. A lot of them had been categorized as Prader-Willi syndrome, but subsequently found out that without genetic testing, we can't really make the diagnosis. And that was what was gotten in 13 of them. Wille in 2023 talked about a 14-year-old who had presented on account of gaining of weight from birth. He was actually born 5 kg and then subsequently started gaining weight at an exponential rate. He had presented then in their clinic at age 14 when he was not attaining puberty. So they had reviewed then and looked at clinical features, then did some chromosome analysis for which they were able to find out that he had Prader-Willi syndrome. And as what was done then was to do some lifestyle modification also for him, and then also had testosterone replacement therapy and vitamin D deficiency. Now to the genetics. So this is what normal looks like. So I'm sorry, it's not really showing there. So the normal one shows a copy from the father, which is in blue, and a copy from the mother, which is something that looks like pinkish red there. The commonest cause is the first one, paternal deletion. So at the critical region, which is position 11 to 13 of the long arm of chromosome 15, there's a deletion there from the father's side. So the genes that are important there are gone. And then because they are gone, the signs and symptoms that usually show those phenotypical features are what we now see when that occurs. It occurs in about 70 to 75% of patients. The second one is uniparental disomy, where the patient inherits 2 copies of the maternal chromosome, and that is what our patient had when we did the analysis, and that constitutes about another 20 to 25%. An imprinting defect constitutes about 1 to 3% of them again, and in that one, the paternal genes are present actually, but they are not expressed, they're silent. So in that particular case, about 1 to 3% also present. And the last one here, though not so common, which is why it's labeled as 0.1%, is when there's a translocation. So there's like a rearrangement of the genes on that chromosome. And we can see the paternal chromosome, there's a part that is short, another part that is extraordinarily long. And the maternal chromosome is still looking okay for in that diagram. So these are the ways that they can actually present, commonest to the least common way that they can present. May is the Prader-Willi Syndrome Awareness Day. It's celebrated all around the world. We hope we can actually have that day celebrated really here in Nigeria. We are hoping to get your cooperation to also help us celebrate at your different centers. And thank you for this opportunity.
Good morning, everyone. While my presentation is being retrieved, I thank EMSON for the opportunity, the COC, the EBSCO, for the opportunity to talk about Prader-Willi syndrome, because I actually crashed into the program. The program was basically set, but 2 months ago, I was sponsored by IPSO, the International Prader-Willi Syndrome, to go for the Prader-Willi conference in Arizona, USA, where parents also were there. And then I saw that there was a structure for children who had this condition in other continents, especially US. There were about 40,000. Their parents were being encouraged, empowered, and there was no data from Africa. And it's not because, or the data from Nigeria. We are 260 million. And if we're so many, it means that we're missing Prader-Willi syndrome. Okay. Thank you. So I will be continuing the presentation by talking about the clinical features, diagnosis, and management of Prader-Willi syndrome. So these are my disclosure. IPSO sponsored me fully for this conference. So clinical features of Prader-Willi syndrome. There are some major findings that when we see them, even if it's one, you have to think about Prader-Willi. Profound neonatal hypotonia. They actually describe like they have a ragdoll feel. I don't know whether some of us have our kids who they have dolls that are rag dolls. Because when you carry a neonate, they should have some tone. There's a way when you pick up a neonate, they have some tone. But these children with Prader-Willi syndrome, they're very hypotonic. There is also a closer syndrome to us that is more common, Down syndrome, that can have that. But most children with Down syndrome, when you look at their face, you will see the mongoloid slant and epicanthal fold, small, low-set ears, and all those. So, but if you're seeing a very hypotonic infant who doesn't have features of Down syndrome, you must think about Prader-Willi syndrome, and especially when this infant has a micropenis. In fact, one old professor I met in Arizona, she said that if she has a house officer or or a resident who sees a hypotonic infant and micropenis and doesn't screen for Prader-Willi syndrome, they will get an extension in her unit. So this baby that was not eating was so hypotonic, failing to thrive. By the time they're growing older, they now start eating excessively. First, the parents are happy that, oh, this child can finally eat. But then it gets out of hand. Then they have puberty delay. Then they could have short stature. That is because for you to say that someone has a short stature, you must see their target height, the mid-parental height, their own potential height they're supposed to acquire. But when compared to the family, you will see that they have a short stature. Then they can have global developmental delay. Then there's some other findings. They are called minor, but sometimes it may be the only thing you will pick. So, in utero, the mother may have noticed a decreased fetal movement because by 18 weeks, quickening should start. A baby should start kicking. Then, infantile lethargy, as I talked about. Behavioral problems during infancy, they might have tantrums, they might throw tantrums, they might be fixated on things. Autistic children can do that as well, but of course, autistic children do not have hyperphagia, so that will also set off the alarm for us. They may have scoliosis, then they notice to have thick, viscous saliva. In fact, some of the saliva stick to the teeth, and they may stick to the corners of the mouth because the syndrome somehow, though it's not fully understood why that happens, they have reduced salivary flow. And then the salivary proteins are more. And so it's very thick. The saliva in them is thick. And this actually happens in this syndrome. There are rarely other syndromes that produce this thick, viscous saliva, viscous saliva that they may have. And then a gift they have is that they're very good with concrete thinking. They have strong visual memory. So they're exceptional at jigsaw puzzles solving. Then these are the institutional phases. So they have hypotonia at birth. Then by 9 to 25 months, their appetite improves. They're not eating excessively. So they start growing appropriately. From that low weight, they start having normal weight. But by the time they get to 2 to 4.5 years, their weight increases. Appetite now starts increasing. They're eating. By 8 years, they are eating. They never get filled. And of course, if they are where food is available, so they eat. Then 8 years to adulthood, they are hyperphagic. They rarely feel full. And in adulthood, many of them will eventually now be able to put a cap on their appetite, but some adults still eat excessively. And sometimes they can actually eat so much that they can crave for food so much, they can eat from the garbage. They can steal money to buy food. They can eat things that are not edible, just to satisfy that craving. And so, diagnosis, who qualifies to be sent for screening? At birth, if there is hypotonia, you will be improving gradually, but it means that you must think about. In fact, if you have a hypotonic infant that is not improving, then think about Prader-Willi syndrome so that you can intervene on time before the hyperphagia stage really sets in badly. Then 2 to 6 years, delayed developmental milestones. Then by the time they're 6 to 12 years, we're thinking about excessive eating. Then cognitive impairment, we know Prader-Willi syndrome with impairment. And in the case that we presented that was weighing, the adolescent that was weighing 150 kilogram, everybody was wondering, what's the academic performance? He's in second year in the university, but yet he wanted to commit suicide because he's eating uncontrollably. He's just eating, he doesn't get food. So it's been shown now from data that 10 to 25% of them will have normal intelligence, normal cognitive ability, smart like everybody is, but it's just that this excessive eating, of course, will embarrass them because when they come to a buffet, it's horrible. They can take the plate, they can take all the food Because in Arizona, they had to tell everybody that, okay, bear with them, and then they told their family members to be following them closely, because once there is food, they can't just take everything they can eat. Then, when they are more than 13 years of age, then you see that they don't go into puberty, and they may have behavioral problems, compulsive or obsessive compulsive disorders, and that's why they pick their skin and skin picking. And another thing that now predisposes them to really pick their skin excessively is that they have a high pain threshold. Nobody knows why that happens, but they can be having, some of them in the adult homes that they presented in Arizona actually had gastric rupture because they ate. They didn't feel discomfort. They keep eating. They had pain. In fact, one had ruptured esophageal varices, but yet no pain, was calm, and everybody thought he was well until he was rushed to the emergency room when he went into shock, and he died. It was at postmortem that they saw that he had massive GI bleed, massive signs that he didn't show any pain to. So, genetic testing, Dr. Kemi has shown us nicely what the DNA methylation, how they can be diagnosed and all. And luckily, because in the past, I'm sure Professor Samuel will know, genetics is not my thing. So, they said that the DNA methylation assays in the past couldn't differentiate it from Polyneal DeLonge syndrome, and there are different different features, but now that they have this methylation specific multiplex ligation probe, it will just clean the diagnosis for Prader-Willi syndrome. So how do we manage? When they are young, you might need special nipples to help them suck from the bottle. They might need nasogastral NG tube feeding. In childhood, you want to supervise their food intake. So their family members are really stressed with this because you have to lock food and make sure they don't have access to food. And in a place where, and you can imagine a child that is not doing well in school, is eating so much, he's short, he or she is short, is fat, so it's in quotes an embarrassment to bullying. And so they are perfect candidates for bullying from the family, for even feeling that you're just embarrassing me. Or maybe the child is so hungry, they haven't started serving food in a party, and he's smelling food, and they've set the food at the back, and he just goes there, collects the food, and start eating. The family will not take him to a party next time. So, in fact, they will flog him seriously, for that day. So, rare is real, like as I keep saying, and all of us in this room, we manage cases that are rare. But to families and to individuals who are affected by those diseases, there's nothing rare about it because it's their reality, and we must be there for them. So we encourage physical activity, developmental services, and educational support. Then hypothyroidism, hormonal treatment for it, HCG sometimes can make the testes to come down. Otherwise, they will do fixation of the testes for them. Then growth hormone therapy really normalizes their height, it increases their lean body mass, it helps a lot, but it's not available here. But I have to sound a note of caution for where they use growth hormone therapy for them, because initially when they started giving them growth hormone, they just saw that within 1 or 2 months they would just die suddenly. Then they found out that the growth hormone, because they were fat, they had obstructive sleep apnea, the growth hormone was improving the growth of their lymphoid tissue and all the areas, in the neck, and they would just obstruct and just die suddenly. So they must do sleep studies before we start them on growth hormone therapy. And then at puberty, we give them testosterone. Then for skin picking, topiramate and N-acetyl cysteine has been found to help modulate the glutamate levels, and it makes behavioral modification for skin picking. It has helped a lot. And then if they developed type 2 diabetes because of obesity, we treat for that, or hypothyroidism. Also because They are prone to osteoporosis. Calcium and vitamin D supplementation is important. It's a multidisciplinary approach because you need the psychiatrist, the endocrinologist, the orthopedic surgeon if they have scoliosis or hip dysplasia, and then the dentist. They give them things. They encourage a lot of water intake, to drink a lot of water to improve saliva, to improve the moistness in the mouth. And then also because combined with thick saliva, which is supposed to just cleanse the mouth, bacteria stay there, and because of a lot of carbohydrate meal, they are prone to dental caries and tooth decay. And of course, we cannot overemphasize the importance of social work support and care coordination. So we monitor them, surveillance. When they are babies, if you diagnose them early, you monitor their anthropometry in infancy. Every 6 months until age 10, we now sit them and monitor annually. You assess for behavioral problems from 2 years of age, psychosis when they are adolescents and adults when they come to you as adults, vision issues and sleep issues, DEXA scan every 2 years from adolescents. I'd already talked about the sleep study before growth hormone, and managing their access to food. So in Arizona, in May, everybody was happy because families were the most important thing that was really bothering them was this hyperphagia. And because their parents can't travel, nobody, because someone has to be protecting them from excessive food intake. But now FDA finally, out of all the drugs that were being tried to manage hyperphagia, Vicat XR, which is dioxide choline, has been approved because it really, really has improved their quality of life in managing hyperphagia. Okay, thanks. And because hyperphagia is a very, very, very serious issue for them. Professor Harlan he's a psychiatrist that is very involved in Prader-Wille research. There was one 14-year-old in Singapore that was going to be sentenced to prison because he stole a woman's purse, just snatched the woman's purse and went to go and buy, because he needed money to go and buy food. You can imagine that if that was in Munshi, that boy risked being lynched. And so they were going to send him to prison. And when Professor Tony Harlan heard, he traveled on his own cost with his money to go and defend him, that it was because of the genetic syndrome he had that had that listed. And that was how that boy was saved and, put in a home and all. So in conclusion, when I checked online about Prader-Wille in Nigeria, we found a first case that was reported by Professor Irede 34 years ago in 1991. But eventually, when we found the full paper, we saw that he was in a Caucasian infant in Jos. So, really, there is no report. But an educationist wrote a chapter in a book on disability, intellectual disability and all, and said that they are known by these traditional names of, I don't know whether our Yoruba people know Ara Asanjo, because I've been asking Ara, my husband said he doesn't know. It means, because at least Ode means a stupid person, a dull person. Arara means a short person. Okay, what does that mean? Ara Asanjo means too fat. You're so really Prader-Wille, this cartoon captures it, because at birth, I don't know, this thing is too wide. At birth, the baby is like a rag doll, and the baby is refusing to eat. They are feeding. Then all of a sudden, he's just eating, and then the father says that this boy doesn't have interest in girls or football or anything. He's just eating, and your balls are not in the right place, meaning undescended testicles. So, in conclusion, we want to maintain a high index of suspicion, and then thanks to IPSO, there is free genetic testing. In fact, they will say that you should not send it by courier. You should send it by normal registered post so that you don't spend a dime. So on the banner there is a scan, a barcode. If you scan it, you will fill in your emails. They will give you information. You can get more information, and any suspected cases you have, once you fill the form and it fits in, they will give you information on how you will send sample. And if you have issues, you can always contact us. So please, everybody in this hall, we are saying that help to find these children, help to help them and their families. There are families from the United States and other countries where they're established who have volunteered that any families, they can partner with them, they can take them through, they can help them get a lot of support. So please, let us stop the stigmatization and derogatory labels. It will not help anyone. So we are united in hope to give care to these children. That's a girl from Norway. She has Prader Wille. She and the mother, they came to Arizona for the conference. And in the middle, it's Dr. Membere. She's from Kenya. Two of us were sponsored to come for the conference in Arizona because they also have identified 3 cases in Kenya. These are my references, and thank you very much.
Thank you very much, the dual team of Dr. Ashuko and Dr. Oyenusi. Now the floor is open. One here, anyone, so that we know the people who are asking questions. 2 on the same table. Okay, Professor Kolawole. Okay. So we'll take those 3. Professor Kolawole, Professor, and I can't see the 3rd person, but please give them the mic. Thank you very much.
Thank you very much, our chair. And thank you, Dr. Eunice and Dr. Kenya, for the very, very illuminating discussion on Prader Wille syndrome. I'm just, mine is just out of curiosity, that in the symptomatology, the way these patients manifest, especially the hyperphagia and co, did you come across studies that are done insulin disposal, the glucose disposal rate and insulin sensitivity studies in this patient? Especially now, you said the medication, diazoxide, the same medication also works for insulinomas. So is there a connection? I mean, there are glucose disposal rates and insulin sensitivity studies. Do we have any information on that in these patients? Thank you.
Thank you very much, Professor Lu.
Thank you, Professor Oyenusi, for the presentation. I was just wondering, the syndrome starts from early childhood with significant loss of tone. Does this tone improve with as the child grows older, or it necessarily needs an intervention? But I was wondering, the story of the 14-year-old you described that snatched a purse to buy food, that child must be, if anything, hypertonic. If anything, hypertonic. I mean, and it's a syndrome that is strongly correlated with hypotonia. Then I like the awareness creation. The importance of that to us is that if you don't know it, you will not see it. If you don't look for it, you will not find it. So nonetheless, it's appearing to be a rare entity in our country. How much of it do we know? How much of it do we look for? So I think it's a very important reminder that you never say never until you really look out for it. Thank you very much.
Someone at the back. After which we'll come back to Professor Anuma.
Thank you, Ma, for the presentation. I have a couple of questions. Our patient was presented as a female. I'm interested to know the male to female ratio. And if they are not treated, what's the lifespan like? Can they get to adulthood that will make maybe beyond 40? I would like to know the lifespan. Cardiometabolic risk, the ones that we have, has anybody tried to do cardiometabolic profile to know what we can get in them? And then, is there any symptom, apart from the hypotonia, are there other things that change into adulthood? I've come across one particular lady in her 20s. So I'm now in retrospective thinking now. It might actually be Prader Wille. Patient eats a lot, insatiable, obese, and has some mental incapacity. So maybe this is actually a case. Thank you.
Thank you. And then Professor, any mic, roving mic? Here. So after this, we should allow them to answer the question. I guess it's a very interesting thing.
Thank you very much, Professor Yenusi, for the interesting presentation. I had, in the abstract session we had earlier, I had actually appreciated the pediatrics endocrinologists for bringing some of these cases to us that we will hardly see as adults, but you people have the privilege to catch them, as children. I just want to find out, do you think GLP-1 analogs will be beneficial to them as regards weight reduction and even the issue of hyperphagia? Do you think they could have a place in their management?
Since I'm the chair, I have two questions. So after that, they will answer. I really like saying rare is real, because when this thing happens in one person's family, it's like 100%. So my first question is, can you do a prenatal diagnosis? Because the patient that was presented, the mother is in the 40s, 41 or 42. It's really a rare age for a woman to give birth. But that's apart. Then the other one is there any difference in severity, whether it's from the paternal or the maternal or both, in terms of the phenotype or presentation? Thank you very much. So,
thank you very much, our teachers, mentors, and colleagues. I'm very happy that everybody's interest was kindled in this topic, and we appreciate that. So, from Professor Kolawale's question, the studies that have been done in them shows that they have increased insulin sensitivity and relatively lower insulin disposal rate. And so it's a bit different from other people who have obesity and all. This is what has been shown in them. And then I agree with Professor Oloko that for you to snatch somebody's pulse very fast, it means that your tone and your reflexes are sharp. Yes, most times the severe hypotonia is when they are babies in infancy. So their tone now starts improving. But of course, they don't really, some of them don't have that perfect tone. And so some of them that don't get growth hormone are still hypotonic as they grow older. But the one interesting thing that actually, and that's why we need data from our own patients in Nigeria, in Africa. I met a mother because in Egypt they have a patient association, and it was the mother of a child with Prader Wille that came. They have like 10 of them parents supporting themselves. And what she said was that they found out that in that Egyptian cohort, those children never had hypotonia in infancy. So it may just be that some people will not have hypotonia. It's just like the intellectual disability, because like 40, 50 years ago, it was like Prader Wille is equal to obesity, mental retardation, and that's or there, someone that is very stupid. And then, but now it's clear that some of them are very sound intellectually, but of course, by the time you see hypogonadism and hyperphagia, they now screen them and see that they have the mutation. Then GLP-1 analogs, yes, ma'am. Because there are like 5 drugs that are passing different clinical trials, and they are trying GLP analogs for them, but I think the trial is not complete. It's only Vicat R, that XR that have passed the 3 phases of clinical trials and been approved for now. Prenatal diagnosis, not that we know of. They haven't. It hasn't been possible to diagnose prenatally. For now, it's in the neonatal period. That, but of course, if a family has it, but I didn't prenatal diagnosis for Prader Wille syndrome. Severity. Wait, do you talk about something about severity? Okay, yeah. Genetics.
Okay, thank you very much, ma'am. In terms of the presentation, when they have the one that has to do with paternal deletions is most severe, because what happens there is that they have lost that section between points 11 to 13, which are critical areas for them. So because of that, they tend to present with more problems than those that have either 2 of the chromosomes from the mother, or those that have the imprinting part, which is just a micro deletion in that part of the chromosome. So the ones that present with the paternal the micro deletions, those have worse clinical presentations than the others. And I think there was also a question about the male to female ratio. It's 1:1 for the person that asked. Thank you.
Thank you, presenters. I think one other take-home message is any patient that looks syndromic, we should take a closer look. It may just be Prader Wille syndrome. I'd like to thank Professor Ikem for chairing the session. Thank you, our speakers, for making it a very interesting one. Dr. Yunusi, we thank you. Dr. Ashibu, we thank you. And of course, without the audience, what would this session have been like? So thank you for being very attentive. Thank you for your comments and questions. And with that, we declare the session closed.